Let's start again. And I would like to introduce Professor Colin Hopper at University College Hospital in London. Thank you, Professor.
We're going to go through some of the papers that have been published on PDT to try and provide you with an evidence base for the clinical effects that you get with PDT. Just about all of this is related to my work in head and neck cancer management, but of course it's applicable across a number of specialties. So head and neck cancer, 6th most common in Europe. It's quite a big problem here in Brazil. You've heard about the drugs that are in clinical use. These are the main ones that are around. And I'll just highlight some of the evidence for these top 3. We've spoken about the treatment parameters. And let's start with ALA, which you know is a heme precursor. And we're looking to build up our drug level of protoporphyrin 9, which is the active drug. Now, many years ago, we did some CCD images, and this false color image shows the accumulation of PP9. So protoporphyrin 9 is here, where it's shining bright white, which maps almost exactly to the epithelium. So the depth of effect you're going to get with ALA, I know there are ways of modifying the depth of effect, but the depth of effect you're going to get is going to be limited to probably the epithelium. And this is the Histology Post Pdt that shows that the epithelium is just essentially just wiped off. Now, I could show you, this isn't a brilliant picture, it's quite an old one, but this is an early invasive carcinoma of the floor of the mouth. These are just mandibular tori and they're irrelevant. So I could show you a picture like this, show the effect after ALA PDT. This is systemic, this is oral ALA given in 3 divided doses. Quite a brisk effect there, and there when it's all healed up, it looks beautiful. Lovely, nice effect. And this patient was certainly alive 15 years after this. I think last I saw of her, she got an esophageal cancer, so she may not still be with us. But this is more typical of the ALA effect. So this is severely dysplastic mucosa in a patient who's really not terribly fit. He worked for Jimmy Choo. He made shoes. And my research fellow, my PhD student at the time, Kathy Fan, is quite a fashionista, and she used to get her shoes from him. And after ALA PDT, this is what we have. Rebiopsy this, and it's invasive cancer. So really, the evidence for the use of ALA in oral cavity cancer is not great, although it does have quite an activity in pre-malignancy, and this was published way back in 1996. Unfortunately, the poor patient died of a myocardial infarct, and Kathy's shoe supply ran out. Now, I've shown you this before. This is the effect of photofrin, and there's beautiful preservation of the underlying structure. So here's a clinical case, multifocal field disease here, at least 5 areas of invasive cancer. Treatment options are a bit limited here, so 1 course of PDT, and there we are, the whole of the mucosa is normalized. So we learned that this really was quite a useful effect. This patient went on to die of disseminated disease several years later, but that's quite an impressive effect. The big problem, of course, with photofrin is the late phototoxicity, and that's always going to be a problem. There are a couple of papers about this. Effective but non-selective treatment, and this is one of many talking about the treatment of field cancerization of the oral cavity. And if you want to see a review article, then something like this, Vanessa Schweitzer, looking at the treatment with PDT of using photofrin for in situ up to T2 squamous cell carcinoma of the oral cavity and oropharynx. As I've said to you before, most of my experiences have been with Foscan, and I'm going to concentrate on this because this drug is licensed in Europe for the treatment of head and neck cancer. Its effects are vascular, and there is some disruption of the architecture of collagen and elastin. So you would predict that treatment would produce some scarring. So here's one of the earliest patients I treated. This is severely dysplastic mucosa, and this erythroplasic area is a large area of microinvasive disease. So Surgical treatment of this, well, cut the whole thing out. Probably need a free flap to fill the hole. Here we are after treatment. Nasty mucopurulent slough. Here, when it's all healed up, there is a scar band. So it's exactly as we predicted. There's some scarring, but here we are a year after treatment. I don't know if any of you have got your eyes plugged in today, but you see the date. This patient was treated in 1996. I've seen him this year. He comes back to say hello to me, and he still looks like this. Look how beautifully moist the mouth is. No radiotherapy effects, no functional effects, no aesthetic effects. Absolutely perfect. Now, I must give him some credit because he was an avid smoker and he gave up smoking. So smoking cessation programs are an integral part of getting a good outcome. But let's concentrate on the evidence. I'm going to go through these in turn. There are a number of studies which I'll go through one by one. I'm going to start off with the so-called 01 study, which was looking at early oral cancer. You would think a surface treatment, the best target would be early cancer, that you could destroy the totality of it. It would seem logical. So we designed this prospective multi-center study, 15 centers, 6 countries. I think it cost several £1 million to do this study. It wasn't all the wine bill from the writing up of the paper, I promise. But it was quite an extensive study. And this is the sort of thing that we treated. So here we have a lip cancer. It's quite irregular and it's quite large. Here we are after treatment, minimal scarring, and certainly a preferable effect to surgery. Cheek, after treatment, 2 days, 1 week, 3 months. The tattooing is because this is from Alex Kubler, my German colleague, and the Germans are seriously into their tattooing. But you can see it's a very nice result at 3 months. Floor of mouth, again, quite a while to heal, but at 2 months, absolutely perfect. And this says the submandibular duct is okay. It had migrated proximally, but it was still fully functional. Another lip, look at this. Surgical treatment of this, well, what are you going to do? Take out that. That's not going to be a very good functional outcome. At 1 week, I'm sure everyone was losing a lot of sleep, wondering how it was going to end up. And at 2 weeks, it didn't look much better. But by 2 months, everything had healed up very nicely with a competent lip seal and reasonable cosmesis. Certainly preferable to anything that you could do surgically, such as this. Here we are with a very dysplastic mixture of cancer and pre-cancer, lip shave, wedge resection, carapansic flaps. You're not going to be telling any wide-mouth frog jokes after you've had that kind of surgery. Sorry, you may not keep up with some of the references, but I do apologize. That's not a great outcome. Now, one of the questions we were asked in this, what happens if you get a partial response? Well, this is what happens if you get a partial response. This was called a T1. That looks like a T4 to me. T4 invading extrinsic muscles of the tongue. This is invading extrinsic muscles of the tongue. But here we are. Nice evolution of effect. But here we are. There's at 4 weeks, there's this sort of granulation tissue that doesn't look quite right. And on rebiopsy, it was persistent disease. So the patient went on to have further therapy. So what were the results of this? Well, we only had a couple of in situ disease patients, and they had 100% clearance of their disease. T2 patients really didn't do so well, and you can understand why. If you have a T2 patient, the difference between T2 and T4, especially in the tongue, is a bit of an arbitrary thing, and that's just under 60%. T1, 90%. Now, this was what's called an intention to treat study. So whether the patients got per protocol treatment or not, they all went into the bottom line. So these figures are as bad as you can make them statistically. Nevertheless, this is quite a respectable outcome for this group of patients. And we wrote this up back in 2004. They went to the regulators and said, look, we've just done this fantastic study that shows that we can treat early oral cancer with PDT. And the regulators said, so what? We don't want to see that. We're not interested in that. Okay. So that led on to what they did want to know about was safety and tolerability in patients with advanced disease. So this is the next study, open label study, 128 patients. Primarily looking at clinical benefits based on a University of Washington questionnaire, and purely as a secondary objective, tumor response and survival. That's what they wanted to hear about. So we were looking at recurrent refractory second primary disease in the head and neck, deemed untreatable by an MDT, no restriction in size, site, or depth. Now, I've seen some pictures from Chile and some from Bolivia. I wouldn't like to be including some of those patients. Ours aren't quite as big as those. Okay, social and demographic detail is probably irrelevant, but typically male predominance. Now, it's interesting when you look at the previous treatments these patients had had. So this is the 128 of them. I might have to put my glasses on to see here. If you just take radiotherapy alone, radiotherapy 23, 59, 69, 72, 88%. 88% of them had had at least one modality of radiotherapy. So heavily pre-treated group. The assessments, as I said, on UOW questionnaires, and these were the response rates in terms of quality of life. To summarize, 50% of patients got a 2-point improvement or normalization of quality of life, and that was across the board for all patients. Regardless of the size, site, or anything else, there was a clear quality of life benefit for these patients. We actually looked at the tumor response criteria, and that was interesting again. Complete responses, 13 overall. There's a slight difference in the numbers that's really due to intention to treat versus patient compliant. So you'll notice there's a difference between 13 and 16% as we go through, which I can explain at some length if you have trouble sleeping. But 13%. Now, 13% complete response rate. What do you think about that in this group of patients? How does it compare with anything else? Well, let's look at some of the chemotherapy. These were per protocol, so this is the 16%. But you look at all the chemotherapy studies in this group of patients, and none of them reach double figures. You will find when it comes to chemotherapy studies, they will always quote overall response rates. So they'll have complete and partial responses. Okay, be very careful of that kind of analysis. Because if you respond to treatment, you will get a much better outcome than if you don't respond to treatment. I think this is from Kowalski from just up the road. And in fact, that proved to be exactly the case in this study, that the complete responders had a 73% one-year survival, and the non-responders had a 32% one-year survival. So basically, if you don't get a complete response in head and neck cancer, you're going to die. Let's keep it simple. Okay. Now, if you're able to illuminate the total volume of disease, that's one thing, and I'll come back to that. But what if you don't get a complete response first time round? Well, you can go for retreatment, and a small number of patients were retreated, and a considerable number of those went on to get a complete response. So that's the other thing. This is a repeatable treatment. And this is the kind of patient we're talking about, heavily pre-treated, and here he is with a complete response. So this is a really tough group to treat. I didn't take part in this study. I reviewed all the evidence from it, but I'd moved on to interstitial techniques by then. Toxicity, everyone asks about toxicity. Very few severe toxic events. Most of them are mild or moderate. So as a result of this, Anil de Cruz and others wrote this up back in 2004. This is how the drug got a license. That's the official story. I'll tell you how the drug really got a license. It was turned down first time, and we had the opportunity to go and appeal against the European Medicines Advisory Agency decision. And we gave a very brief introduction, and I just said, well, there's an unmet need here. And I showed this patient. I said, she's clearly had surgery, she's had radiotherapy, and there she is after treatment, slightly mutilated. And after a little while, she develops this little area of breakdown here. And then you wait a little bit longer, and the whole thing starts fungating through the face. I left this slide on for the rest of the meeting until the people from the Medicines Advisory Agency were doing this. And that's how we got this drug licensed. I'm embarrassed to say that that's what we resorted to, but that's the way it was done. And in fact, it's now indicated for palliative treatment in patients with advanced head and neck squamous cell carcinoma, failing prior therapies, or unsuitable for radiotherapy, surgery, or systemic chemotherapy. Now, that opens the door to a lot more patients who have cardiac comorbidities and things like that, who would meet this indication. So, yeah, it works, all right? You can read the original paper quite easily, but that's a synopsis. Clinical improvement, 50%, and improved survival benefit in those who got a complete response. Now, the Americans did the so-called 08 study, which was very similar. But here they were looking at tumor response and overall survival over a 2-year follow-up period. So 44 patients. The difference, it's exactly the same group here. The pre-treatment was slightly different, but they'd all been fairly heavily pre-treated. The difference was really this, that the tumor had to be less than 5 centimeters in diameter and less than ½ centimeter in depth. So that's actually going to control the size of a tumor that you're trying to treat so that you have a good chance of treating the totality of that tumor. And what a surprise, complete response rates shoot up here to 58%. Now that's starting to sound interesting. Again, the numbers are slightly different, but the message is still the same. You get a complete response rate, you've got a 91% 1-year survival. If you don't get a complete response, you're down to 50%. Now this is admittedly at a much earlier stage in the disease, but that's pretty compelling evidence. And there's a good progression-free survival who get a complete response. Going out for quite some time. This is 1,000 days up here. So, we concluded that this was pretty good stuff. Now at that stage, the Medicines Advisory Agency in Europe wanted us to do another study, which was in patients who had discrete tumors less than 1 centimeter thick, and this was done by Bing Tan. 39 treated patients, 19 achieved a complete response, so about 50%. If it was per protocol, that went up to 68%, and even quite a long way out, 7 of them were free of disease. So that was enough to allay the anxieties of the EMEA. And as I said, this was published 2010 in Head and Neck. Tan was the first author. Again, I couldn't recruit to this because I'd started treating more advanced tumors with interstitial techniques by that stage. So talking about interstitial techniques, this is the way we started off doing it. Then we moved on to these various other aspects of light delivery, and we got some very encouraging responses. Alec Liu, who was with me for a year from Taiwan, wrote this up in 2004, so it's nearly 10 years ago we started doing this. We finished the first cohort. And this is the sort of survival graph we got with a few survivors out at 2 years. Recently we've moved on to using ultrasound guidance. Gergis wrote this up in 2009. We're putting lots of fibers in under ultrasound guidance, and here we are, you can see the way the needles are inserted. You can generate quite large areas of tumor necrosis, and here we are with ultrasound showing how we get into the lymph nodes. Here's a lymph node adjacent to the carotid. You can see you can accurately place these with a standard ultrasound system. Here we are, pre and post, opening up the airway. Adenoid cystic carcinoma is a particularly sensitive target, and that's what this one was. Tongue-based tumours, this is our interim data analysis. We're about 30% survival at 30 months. So That's not bad for patients who have failed other modalities. Evidence for vocal cord cancer. Well, most of this is Merrill Beal. Beal's been working on this for many years. He mainly uses photofrin, but he's produced some fantastic results with normalization of the vocal cords, with excellent preservation of voice. Now, that's obviously very important. I don't suppose anyone in the audience has ever heard of Julie Andrews, but she had a benign condition like this of vocal cord polyps. She went to America to what was considered one of the top surgeons who destroyed her voice, and she's never been able to sing again. Those Sound of Music lovers might mourn her loss, but now if you can do this with PDT with cancer, that's a real step forward. And Merrill's written a review, 2007, in which he includes his laryngeal cancers. He's not published a huge amount in terms of prospective evaluation. That's quite difficult. Nasopharyngeal cancer, this is Bing Tan's work with NIST. It's been published here, so using PDT in patients who have had radiotherapy, and he shows this works very well. This is in the Indonesian setting. I'm sure you're aware that there are 100 million people across the planet who don't have access to radiotherapy, full stop. Now, he did this study in Indonesia. You're supposed to have 4 radiotherapy machines per million population. That's the recommendation. In Indonesia, it's 0.05. So even in a country which I would consider to be at least emerging, that kind of ratio just doesn't add up. So PDT in this kind of environment, you can't lose. What about severe epithelial dysplasia? Can you treat pre-cancer sufficiently well to normalize dysplastic tissue? Well, this is a study we did. We worked out that really if we reduce the drug dose to 0.1 milligrams per kilogram, we looked at different light doses. We wanted to minimize scarring. Now, scar tissue formation, if you're talking about the palate, and this is obviously red patches and white patches, severely dysplastic. This was a dentist, by the way. Here he is after treatment, and here he is when it's all healed up. So scarring's not an issue if you're dealing with the roof of the mouth, but other areas, of course, it is a problem. You've seen this picture before, pre and post-treatment, and from that, we obviously had the histological confirmation pre and post-treatment. But from that, our recommendations are for severe dysplasia that you use this kind of treatment. So 0.1 milligrams per kilogram with 15 joules per square centimeter. Obviously, you need to treat with a wide margin, because unless you're using an optical technique, and you've heard lots of optical techniques for interrogating tissue, which are fantastic, you really don't know where these dysplasias start and finish. You'll look at normal tissue, and if you're removing tissue surgically, you look histopathologically at this tissue and you'll find there are elements of dysplasia. So the genetic events go beyond the field of what you can see. So with these widespread dysplasias, you need to treat them with a very wide margin. And the outcomes, we published our series back in 2011. 147 patients, over 80% complete response, just under 10% partial response. 7.5% progressive disease went on to develop cancer. So this is a condition you have to take pretty seriously. I don't tend to treat mild dysplasia. I'll think about treating moderate dysplasia. I will always treat severe dysplasia. The numbers of malignant transformation, it stacks up that something like 50 to 80% of severely dysplastic lesions will go on to get cancer. And if you've had an index cancer, you had one cancer, and you have associated dysplasia, then your chances of getting a second cancer are really very high. What about the cost of this treatment? I hear a lot about cost of the drug and all the rest of it. Cost is a big issue, especially in our health service in the UK. Well, if you factor everything in, and of course this is not the way people think about it, they think, I've got a hospital, I've got a surgeon, and I've got an operating theatre. They have a routine list every week. Therefore, the established techniques, even if they might take 12 hours to cut out a tumour and reconstruct them, doesn't cost us anything, does it? Well, of course it does. And this is a study I did. It says I'm first author. I really didn't contribute much except the patients and their notes. These are a group of health economists who really did this. And they showed basically Foscan PDT was associated with the greatest health gains, with nearly 130 extra days of life compared with no treatment and extensive surgery, 48 extra days compared with 4 cycles of chemo. Now these have changed because this is a bit out of date now, but unit cost for PDT, £5,700, chemotherapy just under 10,000, and extensive palliative surgery 17,000. Now I know that the charge out rate for extensive surgery, so if you're talking about major ablative and reconstructive surgery with a free flap, etc., is charged now by the hospital at something like 40 grand, £40,000. It is not cheap. Conventional treatment is a convenient way of treating patients, but it is not necessarily cost effective. And this was properly modelled so that if you change some of the parameters, PDT always came out cheaper. Not only that, it comes out better. Trying to get anyone to listen to this is, in government is a bit of an uphill tackle. Now, more recently, there have been a couple of interesting papers, essentially from the Amsterdam group. And what they've done is they've tried to... It's very difficult to do a prospective randomized study. Anyone aware of any prospective randomized studies of surgery in head and neck cancer? Prospective randomized studies of radiotherapy in head and neck cancer? There certainly aren't any on early oral cancer. There certainly aren't any chemotherapy studies. So we're always being asked to provide evidence that conventional treatment has been unable to deliver. I don't know how you feel about that. I feel a bit aggrieved. You go to government agencies, funding agencies, and they say, show me the level 1 evidence. Show me the multi-center prospective randomized studies. I say to them, well, show me the prospective randomized evidence for any treatment we use in head and neck cancer. If you're dealing with a common disease, like breast cancer, where the chemotherapy people can do lots of studies comparing one drug with another, that's fine. But it doesn't work like that in head and neck. It might do in somewhere like India or possibly Brazil. You might be able to do it. But the way Barris and Bing have got around this is they matched their own institutional... they tried to get a cohort where you could compare the results of their surgical technique against their PDT. Now, this is not precise science, but it's interesting. So, disease-free. Here's surgery, here's PDT. So on that, surgery is slightly better. None of this reaches statistical significance, I hasten to add. So there is a slight benefit from surgery here, but not a particularly great one. If you talk about overall survival, turn things round, just so that I'm not showing bias towards PDT, overall survival with PDT is better than with surgery. Again, not significant. And there has been a systematic review. Devisha, working with Bing and Jan Rudenberg and Max Vitjes, have done a systematic review of all the literature, and really it's pretty woeful, the kind of stuff they've been able to find. And now this is an article that's in press at the moment. It's been accepted, I can't remember which journal it is, it's a European journal. I got confirmation of its acceptance yesterday, so it will appear in the public domain soon. But this is a collaborative project basically between our group and the Dutch group, where there's been an overall comparison between the outcome of the two types of therapy. And all this looks very complicated, but if you just concentrate on surgery, this is survival percentage here, this is surgery, and PDT is just about here, and retreatment PDT is just about here. There really isn't much difference. So if you look at P's up here somewhere, 0.713. So it's not statistically significant difference. So if there's a therapeutic benefit, if you're getting less complications, if you're getting less functional and cosmetic impairment, then I would say that PDT will win out every time. There are a whole series of situations where surgery is not possible. You can cut out one cancer, but if patients get 5 over a number of years, are you going to keep cutting bits out? It's really not terribly practical. And just because we find the whole thing really exciting, here's one of our anaesthetists here, looking suitably impressed by the whole procedure. Here we are putting some fibres into the side of the face here. She's really struggling to stay awake. She must have finished her crossword by this stage. Do your anaesthetists do the crossword during? Okay. All right. Now that's a fairly truncated version. That's a fairly short version. There's a lot of dry data in amongst all this, which I don't want to bore you with too much. Those of you who want to see the original articles, you can happily take this presentation. You can download it onto a disk or whatever you like, and go and seek out the original papers if you so desire. But I think it would be a useful point to start some discussion about what you think the evidence base is. Okay, thank you.
So Colin, thanks for the talk, and specifically considering oral cancers, is there a limitation of the total area that you are going to illuminate? In this case, would you be separated in different PDT sessions if it is, especially for field cancerization or something like that?
Yeah, field cancerization is a real problem. And treating the whole mouth with any therapy, and that certainly includes radiotherapy, you treat the whole mouth, you get totally dry mouth, which is really very morbid. Although you don't damage salivary gland function, it is very miserable. Wherever you can, you try and treat the whole lot, but it may not be practical. I don't think I've ever treated the whole mouth. I think in a couple of patients I've treated the maxilla one session, and then gone back and treated the mandible at a different one. Surface illumination PDT is painful. I said this last time. It's very painful. You need opiates, you need support measures, you may even need nasogastric feeding. You treat large areas, it's going to hurt. But then, so does everything else. If you compare the xerostomia that you get, so xerostomia that you get with radiotherapy, and you can't use IMRT for pan-oral changes, patients would trade 50% of their predicted life expectancy not to have a dry mouth. So they'll moan at you like hell for 2, 3, 4 weeks after they've had their treatment. By about 3 months, they're usually talking to you, and by a year, they'll consider retreatment, if you really do a very extensive treatment on these patients. Obviously, if you can turn down the wick a bit, or if there are certain areas that are dysplastic associated with areas that are invasive, you might use a full dose on the invasive disease, but you might, if there are dysplastic areas, you might cut down. And it's difficult to know what you should cut down to. I'll often cut down to 10 joules per square centimetre if the patient's had 0.15 milligrams of drug, to try and minimize the discomfort and post-treatment scarring. But invasive disease, I whack with a full 20 joules per square centimetre. Try and do it if you can, but there's always there's a cut-off that you just can't do it.
Thank you very much. My question is about how deep we can get some kind of treatment with PDT full scan.
Okay.
What's the most important thing? The wavelength, the doses, and about the margin, the surgical margin, when you use the light
Okay.
around the tumor.
I did cover this the other day, and I'll give you the presentation on it to show how we did it. But in essence, it has to be 652 nanometers. It's very wavelength specific. The drug dose that we use, the full drug dose, is 0.15 milligrams per kilogram, and the drug light interval to maximize tumor necrosis and minimize muscle damage is 4 days. Now, I'll talk tomorrow about dose modification. With that, you can get a clinical benefit, and a subgroup analysis of that big study that was done showed 15 millimeters was the depth with surface illumination. Now, the reason I didn't take part in that study was that wasn't quite enough for me to be convinced. So by that stage, I was putting the fibers into the tissue, and then there is no depth limit. You're constrained by other things. You're constrained by how big a hole you're going to blow in the skin, because if there's no point if you've got a tumor just creating an ulcer. Unless you can get rid of all of the disease, then it won't heal. So, skin infiltration is difficult. But basically, a centimeter with confidence, a clinical benefit up to 15 millimeters with Foscan. Photofrin, 5 millimeters, ALA, 1 to 2. That's my sort of feeling.
Oh, let's thank again. Thank you, doctor.
And I said, I'm quite happy for anyone to take a copy of this because it's got all the references on it. So please feel free.